Yeah. So we're going to speak, we're going to have a session on optic neuritis, which we call time is vision, because of the management involved in this and the vision salvage, what we can do if we reach a diagnosis and start to manage the patient on time. There's a lot of overlap in these optic neuritis entities. What are the causes with new markers coming up? So they have basically, you could delineate which type of optic neuritis you're dealing with and accordingly manage the patient. But yes, it is very important in the acute stage that you pinpoint you can say a clinical diagnosis and start the treatment. So some of the classifications and what is typical would be covered by Dr. Diksha Katoch, and then infectious optic neuropathy would be managed by Professor Vishali Gupta, and I would be speaking on the neuromyelitis spectrum disorder. So this is a brief outline, and then we could discuss the clinical cases. So before we go, just a brief biosketch of our eminent speakers. Professor Vishali Gupta, she needs no introduction, I mean, but just a few accomplishments, I mean, what she's had. She's a retina and uvea services chief here, and she's an accomplished surgeon with a keen interest in inflammation and infection of the eye, and which is evident from the work she's done on intraocular tuberculosis and fungal infections. And the amount she's contributed to academics is really very difficult to match, I mean, which is evident by 875 lectures, 42 instruction courses, and 268 publications. Plus, she's also she's presently doing a lot of administrative work as well, in the current secretary of the International Uveitis Study Group and the president of the Uveitis Society of India. Of course, if I go into her awards, probably this whole webinar would be all about that. So probably she's no doubt, you can imagine the number of awards she received, and she has a patent for multiplex PCR, which is commendable. So our second speaker is Dr. Diksha Katoch. She's a budding vitreoretinal surgeon, I mean, currently as a faculty here, and her interest is in uveitis and keen interest in retinopathy of prematurity. She did her training from PGI and her senior NC as well. No doubt, I mean, she has the publications, the number of publications she had at this level is creditable, is 63 with 7 chapters in book. And she's also the current joint secretary of Chandigarh Ophthalmologic Society. And so with this brief introduction, I would invite Dr. Diksha Katoch to kindly share her slides and start the presentation.
Good afternoon to all, and thank you, Jaspreet sir, for the opportunity. I'll just share my screen. Am I audible?
Yes, Diksha,
you are audible.
Okay, so the topic given by sir to me is optic neuritis, time is vision, and the classification of optic neuritis and what is typical. So optic neuritis describes a diverse group of inflammatory and infectious optic neuropathies. The advances in neuroimaging and the discovery of new antibodies has changed how we diagnose and classify optic neuritis. So currently, optic neuritis is broadly classified into the following subheadings. The first one is the one associated with multiple sclerosis, which is described as the typical or the garden variety of optic neuritis. And then comes the ones associated with autoantibodies, the aquaporin 4 antibody associated, which is the neuromyelitis optica spectrum, the MOG, that is the myelin oligodendrocyte glycoprotein associated optic neuritis, which is a MOG IgG associated, then a subset which is associated with infections, then systemic inflammatory and autoimmune disorders such as sarcoidosis, SLE, Sjogren's, a subset which is associated with as paraneoplastic syndromes, and then which is the truly idiopathic, steroid responsive and seronegative variety, which is associated with the recurrent inflammatory optic neuritis. So why do we have to classify typical versus atypical? The most common form of optic neuritis is that associated with primary demyelination. And the best known primary demyelinating disease is multiple sclerosis. So this is the one which is typically classified as the typical optic neuritis. By and large, optic neuritis is a clinical diagnosis and based on some typical features. And the typical features described are that the vision loss is acute or subacute. It develops over hours to days. It is unilateral in most cases. Females are more commonly affected. Pain is seen in more than 90% of these cases, and worsens with ocular movements in 87% cases. The severity of vision loss tends to reach its nadir within first 2 weeks, and there are associated field loss in majority. Altered color perception is also seen in a significant proportion of patients, and that sometimes may be more affected than the visual acuity. Decreased contrast sensitivity is also seen in majority, and that may even persist after visual recovery. Then there are certain features such as phosphenes, UTOFs, and Pulfrix phenomena which have been described. Phosphenes are perception of flashes. UTOFs is alteration in the vision based on increase or decrease of the body temperature. Pulfrix is an altered perception of the trajectory of an object in motion. The most important clinical sign is a relative afferent pupillary defect, and it is very important that we examine patients which are suspected of optic neuritis in an undilated fashion, because sometimes the fundus may be completely normal, and in the typical optic neuritis, which is mostly retrobulbar, the disc will appear normal in majority, and the presence of an RAPD is the most important sign that has to be elicited. Typically, the visual acuity will return to normal in majority, and the recovery usually will begin within the first few weeks. If such features are present, we should ask the patient about additional features which may suggest the symptoms of multiple sclerosis, and that include fatigue, tingling at the base of the spine when flexing the neck, any weakness, pain, tingling or numbness in the arms and legs, any bowel or urinary difficulties or incoordination of the movements. A fluorescein angiography generally has no role in the diagnosis unless we are suspecting alternate pathologies. Visual fields, when done, most commonly will show a diffuse pattern. The most typical, however, would be a secocentral or a central scotoma, though altitudinal field effects can also occur in MS-associated optic neuritis. VEP will typically show a prolonged P100 latency with normal or minimally reduced amplitudes. And in the if OCT is done, acute phase will show a peripapillary nerve fiber layer thickening and subsequently thinning of the nerve fiber layer along with thinning of the ganglion cell and inner plexiform layer. And the ganglion cell and IPL thinning may precede the retinal nerve fiber layer thinning. So what is the role of neuroimaging? Apart from confirming the diagnosis, the most important role of neuroimaging is to stratify the risk of developing MS. And for this purpose, we ordered a contrast-enhanced MRI of the brain, the orbits, and the spinal cord. We generally get a T1 weighted image and T2 weighted images. The T2 hyperintensity is very, very important, and it is important to look at the T2 images. Fat suppression, stir, flare, and diffusion weighted sequences are specific sequences which help in better delineation, because they suppress the surrounding orbital fat. So in the MS associated, if we have to look at the optic nerve, the spinal cord, and the brain, the typical MS usually involves the distal portion of the optic nerve, that is the anterior part of the optic nerve. In the spinal cord, MS lesions will be typically located more peripheral, whereas NMO and MOG lesions will be more central. In the optic nerve, NMO lesions will be more proximal. They may involve the optic chiasma or the postchiasmatic part of the optic nerve. MOG optic neuritis tends to be bilateral. In the spinal cord, NMO and MOG lesions tend to be more central. The NMO lesions are generally superiorly in the cervicodorsal region, and the MOG lesions can be actually anywhere, but they may be more in the caudal distributions. In the brain, the MS lesions are typically associated close to the callosocceptal junction. They are ovoid and they are perpendicularly radiating. NMO lesions are also periventricular, but very closely associated, and they are extensive. MOG lesions can involve the brainstem. So this is what a T2 weighted image MRI looks like. How do we recognize a T2 weighted? It may be important for the residents. In a T2 image, the CSF is white. So this image, if you look at the optic nerves on both sides, on the right side, if you see that there is a whitening, hyperintensity of the sheath, but there is a hypointensity in the center. Whereas on the other side, you see a hyperintensity in the center. So this is what a T2 hyperintensity suggestive of an optic neuritis would look like. If you see the brain lesions are typically ovoid. They are located in the periventricular, infratentorial, spinal cord white matter. And the latest imaging techniques allow for detection of cortical as well as juxtacortical lesions. Acute lesions enhanced with gadolinium while the older lesions do not. And this allows radiographic dissemination in time distinction. So here we see the sagittal image on the right. We see these typically perpendicular radiating lesions, and we see the white matter lesions on an axial cut. Whereas NMO, if we are seeing what basically it is shown here is the involvement of the optic chiasm in NMO, and the lesion above is a T2 hyperintensity, and the lesion below is showing enhancement. So patients diagnosed with optic neuritis want to know whether they already have MS, and if they do not have MS now, what is their risk of developing MS in the future? So the overall risk of developing MS in 15 years after the onset of the first attack of optic neuritis is 50%. And if there are no lesions in the brain at baseline, then the overall risk is low, 25%, and then it increases proportionally based on the number of lesions that are seen on the MRI. Other important conclusions are that 15 to 20% patients of MS have optic neuritis as the presenting feature. There is in general low risk of MS when atypical features such as edema, disproportionate disc edema, and absence of pain features are present. In today's era, we use the McDonald's criteria for diagnosis of MS, and for that, dissemination in space, which means more than one clinical site involvement, and dissemination in time, which means lesions which are occurring at different time points need to be met, and for this, we have to take the help of a neurologist. As far as the treatment is concerned, the optic neuritis treatment trial used the IV methylprednisolone 250 milligrams 6 hourly for 3 days, followed by oral prednisolone for 11 days. This has now been simplified to a pulse dosing regimen of 1 gram IV for 3 days, followed by oral. How does IV help? It offers faster visual recovery. However, there is no significant difference in the long-term visual outcomes. This regimen reduces the risk of a recurrence in the first 2 years, but not after that. Oral prednisolone is not recommended due to increased risk of recurrences. And for MS, we have to take into account the disease-modifying agents, which include interferon beta 1, alpha, and beta, glatiramer acetate, fingolimod, and mitoxantrone. As far as the prognosis is concerned, 92 to 93% of patients recover more than 20/40 vision at 1 year follow-up. And the improvement is slightly higher in those with better baseline visual acuity. ROPD will recover in 55 to 92% patient. Visual fields will recover in 55.9% by 1 year. Color vision in 1/3 to most of the patients. Recurrences at 5 years are seen in 19% for the affected eye, 17% for the fellow eye, and 30% for either eye. So I just end with this slide. I've described what are the typical features. In addition, for MS, in CSF, you'll see oligoconal bands. But if you don't find these features, you have to go to a different pathway, which will be discussed in subsequent talks. Thank you.
Thank you, Dr. Diksha, for an overview of the classification and telling us basically what is typical optic neuritis and how to go about investigating and managing it. And yes, because there are a lot of overlap, probably in further presentations, when we finish off with the presentations, we'll have a good discussion on how to go about it. So now I'll invite our second speaker, Professor Vishali Gupta, for her talk on infectious optic neuropathy.
Thank you, Jaspreet, for conducting this very beautiful webinar on a topic that's very difficult. At least for me, I find it very difficult. So Dr. Jaspreet has given me a topic on infective optic neuropathy. So we all know that optic nerve is vulnerable to a variety of insults and infection, and Dr. Diksha very elegantly showed us there could be different causes for optic neuritis, and infection is one of those. Now, when we talk of infections, there are some very typical infections which I have labeled as horses, like tuberculosis, cat scratch, Lyme, syphilis, CMV. Now, these are the kind of infections which you should be suspecting. Malaria, maybe you don't see it that commonly. I'm in the optic involvement. Then there are zebras. Zebras are basically the very non-specific presentations where you have to have a very high index of suspicion, and these are very unusual conditions. So let me take you over to some of these infections. When we talk of tuberculosis involvement of the optic nerve head generally occurs because there is involvement of adjacent retina and choroid. So it's very important to look, like if you look only in this area, you would think there is an optic neuritis going on. But learn to look dilated fundus and look for lesions in the periphery, which may be just patchy vasculitis like this, or more characteristic choroidal granulomas are patches of choroiditis. So once you see this, this is very typical, either TB or sarcoid, but I'm not discussing sarcoid. So think about tuberculosis in these situations. You do the fluorescein and these spots will appear, they will show beautifully as hyper to hyper. And you know what you are dealing with is not just simple optic neuritis, and go ahead with the lab investigations. Other disease, other infection which we see rather commonly is the cat scratch disease. Just remember that cat scratch causes neuroretinitis. So you may be seeing optic disc edema like this, but very classically you will see a star which is centered around the fovea, and typically it might result in a complete star. This is caused by the organism Bartonella. So Bartonella generally affects children and young adults, acute visual loss, unilaterality. Unilaterality is very common. There may be some history and you see white lesions. Very importantly, for example, in this patient, a young girl, you may have a cat scratch disease, but it's very important that you may have associated vascular occlusion. So if you are seeing your optic neuritis with vascular occlusions like this, and this may be progressive, another occlusion developing another site, think of cat scratch as a possibility. There is also predilection for capillary proliferation, retinitis, and treatment. Generally, it's self-resolving, and also important that history of exposure to cat is not necessary always. Self-limiting, number of antibiotics have been tried. So if you wish, you could try those. Syphilis is a great mimicker. So when optic nerve gets involved in the syphilis, it could be anterior or retrobulbar or neuroretinitis, generally in the secondary or tertiary syphilis. And testing is important. Anytime you see optic disc edema with inflammation, syphilis always needs to be ruled out. And CDC recommends that you screen with non-treponemal lab test and then confirm it with treponemal test. Remember, if you have syphilis, always treat as neurosyphilis. Now, this is an example of a patient, 43-year-old man, who was actually diagnosed as papilledema elsewhere, but he had these some vitreous cells, came out to be positive for syphilis, and this is how you treat it. The treatment is with penicillin injectable like neurosyphilis, and you can see the resolution of optic neuritis. Viruses are another very important causes. Optic neuropathy in herpes virus, both type 1 and type 2, may occur in association with retinal necrosis and very rarely with herpes encephalitis. So optic nerve involvement may be either concomitant or actually follow the retinal infection. Now, this is the kind of the infective viral which is seen in herpes. Now, this is the patient with on, and if you look in the periphery, you will find these lesions in the periphery, which are necrotic retinitis. So, anytime you see the disc, which doesn't appear just simple swollen, you are seeing some whitish infiltrates, yellowish white, either involving the optic nerve or the adjacent retina, or there is a macular scar and you have vitreous cells associated with this. These are all the conditions where you would suspect infections to be there. Another common infection which we all see is toxoplasmosis, which may present as isolated papillitis or juxtapapillary papillitis, or there may be distant chorioretinitis. It is very very commonly seen in atypical form of toxoplasmosis in the immunocompromised patient. Now, this is an example of a patient who has optic nerve involvement. You can see bilaterality with vitreous cells, counting finger in the right eye, and he is also HIV positive with CD4 count of 95. So we were not, honestly, it's not really toxo like a horse, like it's not written on your face. So we did the diagnostic PPV, which showed a toxoplasma B1 gene, and the patient was treated with anti-toxo treatment, and you can see the resolution and the healing of the lesion now 9 months later. Cryptococcus is another disease, and these days it is actually mucor. I could not find a picture of mucor, but I have put in a picture of cryptococcus just to indicate how fungus could present as infective form of optic neuropathy. So cryptococcal disease may cause papilledema due to meningitis caused by cryptococcal neoformans, especially HIV patient. And these are the kind of the patient, I'm not saying you suspect cryptococcus in every patient, but if the patient is coming to you in a setting of HIV with opportunistic infection, and you're suspecting some of these are the kind of the patients you should be looking for. Finally, rickettsia, which is again a zoonotic disease, not that we see it in day-to-day practice, but if you happen to have a patient who has been to area where these kind of infections are prevalent, and since these days, well, at least pre-COVID days, the traveling is so rampant, so you've got to keep these in mind. So the diagnosis is basically based on epidemiological data, systemic disease, ocular involvement. It is by and large self-limiting. You may not really have to diagnose it, but if required, PCR. And this is following treatment of doxycycline, but you can just not treat also, even then it will respond. So to conclude, infective forms of optic neuropathies can resemble very closely non-infective forms, but there will be certain clues, and try to look for those very few vitreous cells which might be there, some yellowish white lesions around the optic nerve head or even away from the optic nerve head. Always dilate and see the periphery to see what is happening elsewhere in the retina. So it's important, in short, to have a very high index of suspicion. And thank you very much, Dr. Jaspreet, once again.
Thank you, Dr. Vishali. That was a beautiful depiction of the conditions which can cause infectious optic neuropathy, and very well summarized. We'd like to have you back after the other session during our case presentations.
I'm working on the second one.
Thank you. So now I would be presenting the atypical optic neuritis. So we had a typical, which has been presented by Dr. Diksha, and the infectious optic neuropathy, which is a type of atypical optic neuritis, where we have to ask for investigations if we feel the clinical picture resembles so. So coming to the immune-mediated, which we call the neuromyelitis optica spectrum disorder associated optic neuritis, also commonly called atypical optic neuritis, because it does not obey the visual acuity and the investigative modalities. They're all different for that, and how they present is not that typical. So it's a severe inflammatory demyelinating disease which affects the optic nerve as well as the spinal cord. So many people will present with spinal cord pathologies as well as causing weakness. So it's a distinct disease, and you have antibodies against it with aquaporin 4 and myelin oligodendrocyte protein, which we call the MOG. So aquaporin 4 and MOG, basically, if you have positive, then you call it an NMOST. So the presentation is, there's a lot of overlap in these presentations. So there's no pathognomic way this disease would present. Usually I say it could be a severe visual loss. It could be bilateral, simultaneous optic neuritis. When you have spinal cord involvement, it is like longitudinally extensive transverse myelitis, or you could have intractable hiccups, nausea, and vomiting. So that's a typical area prostrema syndrome. And if you have that one, symptoms of these, probably you could narrow down your diagnosis to a NMOST. Relapsing course, yes, the MOG positive patients do have a relapsing course, sometimes even with immunosuppressive or immunomodulatory treatment. The weakness is because of, again, central nervous system involvement, the spine involvement, the bladder bowel dysfunction, and pain are because of the CNS involvement. So the diagnostic criteria of NMOST was well described in 2015. So if you have these positive markers like aquaporin 4, then probably along with one of these core characteristics like optic neuritis, acute myelitis, area prostrema syndrome, which includes hiccups, nausea and vomiting, or the acute brain syndrome, symptomatic narcolepsy, or cerebral syndromes, or even focal involvement of the brain. If you have a positive aquaporin 4, then yes, we are dealing with some kind of a NMOST. But what happens if you have a strong suspicion, but you get your testing done and it's negative for aquaporin 4? So then what we have to think about is the clinical characteristics. So you have to have two core characteristics, with one of them being out of the most common. The most common means out of these four, either you have optic neuritis, a myelitis, a prostrema syndrome, or a brainstem syndrome. So these are the common ones. So one of these has to be there along with any other to basically diagnose them as NMOST. Of course, they may be negative in the beginning, but after 3 to 6 months or maybe a year, many would seroconvert. So the NMO consortium has said that about 50% of these patients, so they would not present to an ophthalmologist, they could present to a neurologist with the form of transverse myelitis with weakness, pain, or maybe bladder or bowel disturbances. Optic neuritis is seen in 36%. Both of them are seen in 10% and neither in 4%. So when do you want to test for these markers in a patient who presents to you with maybe decreased vision? The aquaporin 4 is positive in 3 to 5% patients with the first attack of optic neuritis without neurological features. So a fairly very less number of people have a positive aquaporin 4. They might seroconvert later, and the way it's tested is also very important. So you need to have the clinical characteristics along with that, which are the two core characteristics. You could have bilateral visual disturbances. That's again atypical. So to have both eyes visual loss, maybe asymmetrical, maybe sequential, or maybe simultaneously, it gives a clue that this is something atypical. Recurrent optic neuritis with poor visual gain, where MRI is not typical for MS, is also a clue that you're dealing with NMOST. Coexisting autoimmune disorders, yes, if you have kind of a maybe SLE type of an issue or maybe other things, you should test for this immune-mediated NMOST. So which lab test to order? Now this varies from place to place, and that's how the literature says you might have a positive antibody or you might have a negative antibody. This is all based on testing. So the most sensitive is the cell binding assays. So again, the specificity is much more as compared to sensitivity. So the thing is, you could have just the negatives. True negatives are much more as compared to the having a true positive. So the ELISA is slightly less sensitive, and previously, like indirect immunofluorescence was done probably just positive in 50% of the cases. So once you test it, and that is one part. So once you have the antibodies to your aquaporin 4 or myelin oligodendrocyte protein, then it's a confirmatory evidence. But yes, there are false positives as well. So the other modality which is very important in helping us manage this patient is MRI. So MRI findings, as was shown earlier in the typical optic neuritis, usually you have like the anterior segment, the anterior part of the optic nerve involvement, whereas in these cases, more than 50% involvement of the optic nerve. There is bilateral involvement. There could be chiasmal involvement as well. And if you see the spine, there's a longitudinally extensive intramedullary lesions which span 3 vertebral segments. So 3 or more vertebral segments would definitely favor a diagnosis of NMOSD. Whereas less than that, probably you would still think about maybe an MS type of a lesion. But yes, follow-up would be very essential in those cases, because what happens is these can be, it also depends when you do these MRIs, it could be patchy lesions. So a single lesion broken up into patchy lesions. So that also, it all depends if you're doing it too late. So the right time probably to do it is in the initial few months. Brain MRI again would tell you what lesions are there in the brain. It's normal in 40% of these cases. So NMOSD can have nothing in the brain. I'm not talking about the orbit or the optic nerve and chiasmal involvement, that's different. But otherwise, if you see the white matter, there could be nothing. Some spots are seen in 46%. It could be MS resembling in 13% of the cases. So these are just to show you some of the images here of atypical optic neuritis, or you can say NMOSD or optic neuritis. You can see here the involvement, the swelling of the optic nerve, and it's way beyond. In case of MS, probably you might just have just the anterior part, but it's extending more than 50%, almost reaching up to the optic chiasma. Just see how it's swollen. There is some, you can say, a perineural enhancement as well. Probably that would point towards a MOG lesion here. So these things, MRI is helpful in this orbital lesion. We are not seeing anything in the brain here. Similarly, you have another case here. Again, thickening of the optic nerve, enhancement in probably 2 regions here, but it's quite thick. So the whole length is involved. It's an intracanalicular portion and going posteriorly from anterior to posterior. This is another case of NMOSD where you can compare. We see here that 1, 2, 3 parts getting involved, and there is some intensity here near the chiasma, and the other eye is also getting involved. So these are some of the features of atypical or NMOSD optic neuritis. And if you see the spine involvement here, you can see here the enhancement, which is probably 1, 2, 3, 4, almost 5 vertebra. So it's more than 3 segment involvement. And this is the central part which is getting involved. It's not the sides which are getting involved. So these are some of the features where if you have a negative aquaporin 4 or MOG antibody, can give you a clue that yes, this is something where I need to treat the patient very aggressively to prevent further disability. So when you talk of treatment in these cases, the acute management is with the methylprednisolone. So whether it's an atypical or a typical variety, the management is methylprednisolone 1 gram given for 5 days. We have to be careful here. Some of them don't respond. So if there is no response, probably the earlier you do the plasma exchange, plexus plasma exchange. So it should be done as early as possible, because the more we delay, probably if you do it after maybe 15 days, the effect is much less. Many still don't recover pre-baseline vision in patients with aquaporin 4 positivity. And a long-term treatment, of course, you would require immunomodulators in consultation with the neurologist. So when you talk of MOG positive, so these aquaporin 4 and MOG and all, I mean, they are part of that neuromyelitis spectrum disorders. But really, if you speak of NMO, probably we are concerning about the aquaporin 4. So this is also, you have an antibody to the myelin oligodendrocyte protein. And this is more often it presents as an isolated optic neuritis, more commonly than a transferred, but usually with transverse mellitus. So it's more of an optic neuritis. The phenotype type is similar to, you can say, an aquaporin 4 optic neuritis. Recurrences are more prevalent, just like chronic relapsing optic neuritis. Earlier it was cryon, but now we've got these biomarkers. So probably we can, they fit into one of these categories. The visual loss at presentation can be profound, but the good thing is that it responds well to steroids because it involves the anterior part more often. Although more than 50% of the optic nerve is also involved, but has an anterior predilection, you have more of disc edema in these cases. So how it can present? A MOG and antibody disease can have a varied presentation. It can present as ADEM, that's acute disseminated encephalomyelitis, usually seen in children. So if you have like ADM in children, probably, then you're more or less going to get a MOG antibody positive response. So in children, this is the picture. What we have is what we call as an ADEM. Then unilateral optic neuritis is seen 31% of the patient. It's a recurrent optic neuritis. You could have a profound loss of vision as well. Bilateral optic neuritis is seen in 24%. You can say longitudinally extensive transverse mellitus in 14%, and a combination in 9%. So it's it can present just anyway. So if you think you have such kind of a picture, what you're dealing with probably, then you can order, you can suspect that it's likely to be a MOG antibody positive. Now, imaging again will help you in narrowing down your diagnosis, because you have more than 50% optic nerve involvement. Chiasma is less commonly involved. The important thing is perineural enhancement, which is very common and very unlikely to be seen in aquaporin 4 or MS-related optic neuritis. So if you have a perineural enhancement, you have more than 50% optic nerve involved, which is mainly the anterior 50%, probably we can order a MOG. So just to tell you about the red flags in atypical, or you can say the atypical signs and symptoms of optic neuritis. So I won't be going with the typical one, which has been covered. The atypical variety probably presents, you can have more than 50 years or less than 12 years. So it's children. So the MOG related events are commonly seen in children, or you can have in young adults as well. The visual loss could be sudden, it could be profound, or it could linger on for a few weeks. The severity of visual loss can be no light perception as well. It could be bilateral no light perception of light. Pain is a distinct marker of, you can say, optic neuritis, but atypical symptoms means no pain. So if you have no pains, probably you're dealing with some kind of an atypical variety. Previous history of neoplasias, paraneoplastic syndromes can present, or you have autoimmune disorders, connective tissue disorders, sarcoidosis and vasculitis can present with this. Optic disc edema is more likely to be seen in MOG-related disease, and it's a severe optic disc edema. Severity would be much less in an MS-related optic disc edema. Then you could have related uveitis or periphlebitis. NMOs presenting later could have just optic atrophy, and then you would unable to regain the vision. In a typical variety, vision would usually recover in 2 to 3 weeks, but here, if you have a aquaporin 4 positive, there are chances that you may not have a recovery. So these are some of the red flag signs which tell you how, which you have to look for and see whether this patient would require intensive management. So this has already been covered. Just to revise it, what it is basically, the laterality of attacks is bilateral in NMOSD, very unlikely in MS. The severity of visual loss is much more. White matter lesions are more seen in MS-related disease. The optic nerve involvement is anterior orbital. It's posterior in NMOSD. The transverse myelitis is rare in MS. You can have just maybe a single vertebra involvement, but yes, it is there. It's common in NMOSD because, as I said, 50% could just present with transverse myelitis. Tissue destruction, cavitation is more in a aggressive disease, which is NMOSD. CSF analysis, proteins are much higher in NMOSD. Response to steroids is good in multiple sclerosis, and reasonably good in MOG-related NMOSD, but it's quite variable. It's difficult to predict in a aquaporin 4 positive NMOSD. So this is just a flow chart which can guide us to approach a case of optic neuritis. So if you're suspecting optic neuritis, you can have typical symptoms or atypical symptoms. So you would order obligatory blood test, maybe typical or atypical. So once you're considering atypical, you have to see if you're dealing with inflammatory optic neuritis, the clinical picture, the history, the symptoms would tell you. Infectious optic neuritis is a beautiful finding as shown by Professor Vishali Gupta. Then you have to be careful about these conditions. These are all, you can say, mimickers of optic neuropathy and optic neuritis, ischemic optic neuropathy, because it can present with disc edema with sudden vision loss. So atypical symptoms. One has to be careful about this, how the patient presents, and you can say the findings on the fundus exam, the findings of the optic disc, see the other eye, whether there's a cup or not. So all these are clues. Compressive optic neuropathy usually would be bilateral. So in the initial phases can present as disc edema. Toxic, usually patients would give a history. Inherited optic neuropathies are slow growing, you can say slow loss of vision over time, and probably a proper history is available. It's not that acute as seen in the optic neuropathies, which are atypical, and other causes like uveitis and all have to be ruled out. So further diagnostics have to be carried out based on what your clinical impression is. So MRI brain and orbit probably would be done in all cases. A CSF analysis where required if you feel there's some kind of an infective pathology in the CNS or which is causing it, or you're unsure of what type of neuritis you're dealing with. Probably yes, along with additional blood test. And the specific diagnosis and treatment is all based on what the final diagnosis is. So the specific diagnosis, I mean, the acute management is, yes, in many cases, if you think of an immune-mediated disease, it would be intravenous pulse methylprednisolone. So if you have typical symptoms, you can consider a MS or maybe a clinically isolated syndrome or a single attack of optic neuritis. MRI brain, of course, that's what you have to do, get done in probably almost every case. So if your suspicion is if we have MRI finding probably on the brain imaging, then the patient has probably high risk to develop MS. The acute management is IV corticosteroids. But if you don't have these findings, the chance of developing MS is there, but you still have to treat with IV corticosteroids. Follow-up and MRI and examination is very important in both these cases, because these patients at the onset, I mean, as I said, there's a lot of overlap. So you don't know what can the patient be having later on. If you might have a relapse in the first year, might not have a relapse for maybe a couple of years. And what happens in the second attack, what amount of vision loss the patient has, how he seroconverts, all these are important. So the follow-up is very important in such case. You just can't leave the patient who has had one attack and okay, fine, just go away. So the acute treatment, as I said, in these cases is IV MP for 5 days, followed by oral steroids. Oral steroids really help in patients with MOG-related disease probably. You have to carry on these steroids for maybe a couple of months. The second line treatment is plasma exchange or IVIG, and these are patients who really don't benefit from IVMP. So if we have a patient who has loss of vision and has probably is unable to regain vision after 5 doses, after considering other diagnoses, he might be a candidate for plasma exchange. Immunosuppressive is a specific therapy to be given, which is a chronic therapy, and obviously this is done by the neurologist, where the first line therapy probably followed is azathioprine and rituximab. Rituximab, yes, you can say lesser dosing as compared to azathioprine. The second line is methotrexate and mycophenolate. So I'll just discuss the algorithm for the management where you have these MOG antibody positive or a negative. How to approach these patients. So this is what I'm going to talk about is like an atypical optic neuritis. So atypical optic neuritis could be just anterior with papillitis, bilateral, an optic neuritis with poor recovery. You're having a recurrent optic neuritis or maybe a transverse myelitis along with. So number of causes as I discussed, I mean, it could be ADEM, it could be brainstem or transverse myelitis. So how do you approach this? So if the patient tests, so you have to send antibodies for aquaporin 4 as well as MOG at the same time, preferably before starting steroids. So in some studies, it has been shown that these results could be altered if you start IV methylpred before sending the samples. So you just take the samples, keep it, and you can send them for the investigation. So if you have a positive test for MOG antibody, what do? You call it a MOG antibody disease. You treat with 6 months corticosteroids or immunosuppressive therapy. And then what happens is, again, testing MOG antibody at 6 months. So if there is no MOG antibodies, probably you can taper off the corticosteroids. But if you have a positive, then of course the onset, the attack, severity of the relapse, severity at presentations could give you a clue that how long you could consider it. So at 6 months also, there's MOG antibody, you have to continue the corticosteroids or the suppressive therapy. Again, test at 12 months. So if there's nothing, taper off. If there is a MOG antibody positive, then probably the patient is relapsed. You have to discuss long-term immunomodulators, which are specific to the MOG antibody. So if you do not have a positive antibody, then probably if you have a aquaporin 4 positivity, yes, you deal that way. If it's not there, then probably you would think of ADEM or MS or maybe LETM, all these things. I mean, these are differential diagnosis, autoimmune disorders, other autoimmune disorders, and other causes of optic neuritis. So that's how you have to deal with patients who present with atypical optic neuritis. So investigations have to be tailored to clinical suspicion. MRI, why you want to do MRI is obviously to rule out MRI of the brain, to rule out lesions other than MS, and maybe if you have MS-like lesions, you prognosticate MS. The other thing is MRI would help you show you the length of involvement of the optic nerve, which again is one of the important signs when you're dealing with atypical optic neuritis. So MRI is really probably even for typical and atypical, you can say MS and non-MS related optic neuritis is a really helpful investigation. CSF analysis is done if you find that you're not really getting along with these MRI or something very atypical, something you find that is suspicious and not fitting into your diagnosis, you could do a CSF analysis along with that. Serum vitamin D, although not directly related to optic nerve damage, but it's a risk factor for recurrent optic neuritis. So always get a vitamin D levels. And in this Indian population, probably people are deficient in vitamin D, no harm in starting out them vitamin D. The antibody testing, yes, if you're suspecting an NMOSD, go ahead. Even when you're having a, you can say, a typical variety of optic neuritis, probably sometimes it's helpful to get these things done if your MRI is normal, and to rule out a vasculopathic, paraneoplastic, infective workup if suspected. OCT is a very handy tool for the ophthalmologist. In the OPD, takes hardly a minute or so to do it. And yes, in some patients, yes, it can help in giving us, you can say, prognosticating and helping us in treat, and sometimes even getting the investigations done. The amount of loss on the ganglion cell is helpful to know the severity of the disease. So it would basically thickening of the RNFL in acute phases. That's if you have a disc edema, probably RNFL will be thickened in those cases. Thinning of GCL IPL is more in NMO. So if you have a severe thinning, probably it would go more in favor of an NMO spectrum. Then clinically, microcystic macular edema is indicative of NMO. You can have wedge-shaped defects, but remember, wedge-shaped defects are more prevalent in ischemic pathology. So in the era of biomarkers, we look at optic neuritis. How we look at optic neuritis has changed. The pattern of optic nerve enhancement on MRI would provide us diagnostic clues to the etiology. And it also helps us understand the mechanism of the disease, thus influence the treatment. So a lot of things, I mean, the MRI provides us a lot of information. Of course, this is added on by getting tested for aquaporin 4 and the MOG antibody. So it's very important to know that these categories, these antibodies and these antibody-associated optic neuritis, they're separate entities with different prognosis, with different presentations, underlying pathophysiology. But yes, there is treatment available. So one should be quick to pick up these entities and start treatment. So we had these 3 presentations which covered almost, you can say, the commoner varieties of optic neuritis. And with this, after this, you can say the theoretical part, probably we have a few cases, and we can discuss those cases here. And I like Dr. Diksha and ma'am, Professor Vishali, if she's available, she can like to have the comments as well when we go on these cases.
Jaspreet, you have a question in the Q&A box.
Oh, 1 minute. Okay,
that is about any role of injection dexamethasone retrobulbary. Retrobulbar, is there any role?
So retrobulbar injection, of course, is a locally acting agent. So it won't affect what is actually causing optic neuritis. So we have these optic neuritis which is associated with MS. So you have optic neuritis associated with the MOG or the aquaporin 4 antibody. So these are systemic problems which need to be tackled with some things which is taken orally or intravenously. These are not locally acting diseases. So probably you can say peribulbar or retrobulbar blocks probably won't, that's not the management probably in these cases. You have to give systemic therapy because these are affected by, you can say, antibodies inside the body. It's not in the orbit, but they do affect the optic nerve. Any comments from Dr. Diksha?
No, I agree totally.
Okay.
No, sir, agree.
Dr. Vishali, ma'am, you would like to present your case or should I go ahead?
I can do that, yeah.
Pardon, ma'am?
Yes, I can do that.
Okay, I'll just unshare my
You have to, yeah. So hello everyone. So we listen to all the causes, all the things which can cause infectious, non-infectious, NMOs, multiple sclerosis. And now Dr. Jaspreet wants to discuss various case scenarios. I will just go through mine and then Dr. Jaspreet would take over. Now this is a patient, 2006, it's a long time ago, 37-year-old man who had pain in the left eye. So he went to an outside center, had disc edema, and as we heard that once you see disc edema, don't wait, just give steroids. So he received steroids, IV followed by oral, and then went to center B. Again, oral steroids were increased, but despite oral steroids, he developed decrease in the vision. Went to center C. They say, well, it could be posterior scleritis / optic neuritis, so undergoes MRI, and even pseudotumor was considered. His vision at that time was counting fingers, and the pupil was kind of hydrogenically dilated, undilated. Pupil, when it was seen left eye, he had RAPD. There was some flare in cells and minimal amount of vitritis. So he was seen by one of our trainees who saw him, and of course it looks like disc edema, it looks like optic neuritis even to me. So it was kind of thought of as optic neuritis. It's meant to be interactive case, but anyways the fluorescein was done, and the fluorescein showed, I mean, nothing very remarkable, something you would expect in optic edema. There was inferior altitudinal hemianopia. The visual field was done by the resident, and he was told to continue on oral steroids because it looked like optic neuritis, to be very honest with you. Now, what happens? What was the major issue? The major issue is the periphery was not examined. You feel so happy looking at the field and looking at the optic nerve and the disc edema that you just feel lazy dilating the pupil, putting the patient on indirect ophthalmoscope, and actually bothering to examine because you don't suspect. So patient was lost for a month, and a month later, when he came on steroids, you can see these lesions which were there. So maybe these lesions were not this extensive when the patient was started on steroids. So you really have to take an effort. But if you remember, I showed you he had 1+ vitreous cells. So probably that means you have to make this extra effort. So what would you like to do now? We did the PCR, but that's more of an academic exercise. It's a very clear acute retinal necrosis, viral, received the treatment, prednisolone was tapered, and you can see over a period of time, this is a long time ago, we used to do laser at that time. Now we really don't do it all the time. So this is what it ends up with. So my only message I would like to give is before starting high-dose IV corticosteroids, like you check for your blood sugar or the blood pressure of the patient, please also make sure that you have examined the retinal periphery in detail, because these cases don't happen every day, but even if they happen once in the lifetime, they teach you a lot of lesson to be followed for the rest of your life. Thank you very much, and over to Jaspreet for other cases.
Thank you, Dr. Vishali. Just one, you can say one comment, opinion. Does the like the picture what you showed? Does the appearance of the disc give you a clue that you're probably dealing with the infiltrative or an infective optic neuritis? Just like this picture was like, it felt something was like infiltrating around rather than a disc edema when you have the peripapillary swelling along with that.
Yes.
So,
because whenever we have an infective component, the peripapillary choroid and the retina tends to be involved. So even in VKH, for example, though that is not infective, VKH might just come with disc edema, but the peripapillary choroid would be thick. So the image or the clinical picture, when you see, it's not very typical. So I think I will not be able to put it exactly in words, but if you see something which does not look very typical of what you have seen, always try to rule out infections as a possibility lurking either behind the optic nerve or somewhere in the adjacent choroid. So it's worth doing more investigations, dilating, and peripapillary choroidal thickness and all need to be done.
Yes,
Because even optic disc drusen, sometimes the residents confuse it. So it needs to be looked into.
yes, and very rightly said that always have a proper look at the fundus. You could miss the periphery, like probably happened in this case. So it's very important that just don't be so happy with the disc, and you need to have a proper examination of the fundus, because you might miss out these things and order unnecessary investigations.
Absolutely.
Dr. Diksha, your comments? Any?
No, sir.
Okay. Thank you, Dr. Vishali. Now we'll move on to some of the, you can say, the typical and the immune-mediated atypical optic neuritis. And just share my screen. So, yes, we have a few cases here, and we do have about half an hour. So I'll just go through these cases. So we have this young lady who comes with blurring of vision in the right eye since 15 days, which is like a sudden onset. So sudden onset, usually not typical, but here she comes, that's what the history she got. She noticed on waking up and associated with headache. So initially it started at the center of a field and gradually progressed over 3 days. So that's some kind of a central scotoma she's having. So this was associated with pain on eye movement. So these are some clinical features. You can say her symptoms probably would be going in accordance with an optic neuritis. She doesn't have any other significant history. So her accounting, she was a myope and accounting fingers close to face. So just see the severity of visual loss. So she has a severe visual loss and a sudden onset visual loss. A sudden onset severe visual loss, what she gives, counting fingers close to face. She has an RAPD in the right eye, and she cannot read the demo plate. Although the vision was very low, we tried to go very close if she could read, but she could not even read the demo plate. The left eye all the findings were within normal limit. So if you have a typical optic neuritis, probably the vision would not be that low in most of the cases. It would be you can say a progressive visual loss. So if you see the disc here, probably there is swelling, you can say, around this nasal margin of the disc, superior and nasal margin of the disc extending to the peripapillary region. So there is, you can say, a mild disc edema and something probably which has resolved in the left eye. It's difficult to say, but yes, there is some blurring in the nasal margin as well here. So when you have the OCT, probably the OCT is fairly normal. You can see some white area here, probably this nasal swelling which is there as in the fundus picture. In the left, the ganglion cell is fairly well preserved. So even though she had symptoms like a profound loss of vision and which was sudden insult, probably we would think of those were atypical features. But when you examine them, her ganglion cell is preserved. That would probably the first to go when you have a severe disease. But yes, the time of doing this also matters. So we did our investigation because it was just an overlap. So basically everything was just normal, just got her antibodies were negative, is awaited, but they were negative. And we had to perform a CSF because everything else was just normal. CE, MRI, brain, orbit was just normal, just some inflammation of the optic nerve probably, and rest of the things were normal. So that's why we had to go in for a CSF. And again, the oligoclonal bands here, which I said is awaited, were negative in this patient. So everything is just negative, negative, negative. It's just a clinical diagnosis of optic neuritis that we have with a sudden vision loss. So the acute management is don't wait, even though the ONTT said the final outcome doesn't make a difference, but we don't know what we are dealing with. It might be just MS related or maybe atypical optic neuritis, which can seroconvert later. So always treat them with methylprednisolone when it's available. So this patient has counting fingers close to face, and after 5 injections, she regains 6.9, and she's quite happy with it. The RAPD was persisting. Her color vision was down as well. So this shows the importance of holding on these patients, managing them aggressively in the early phase, and not letting the investigations rule your acute management. The other case, the second case we have is a 34-year male. Again, pain around the right eye for 3 days and decreased vision since 3 days. It was again, he said, obviously the vision loss was sudden, but it progressed. So it deteriorated over a period of 3 days. There was pain along with diminution of vision. Right-sided forehead, you can say a dull ache he had. But the significant thing was, we took this history, but he kept harping upon repeatedly saying that, okay, I've had trauma to my right eye with a remote control by his child. That was the only thing he was bothered about, and said, this has happened after that. It's happened after that only. So, of course, he's a medical rep. Probably he must be having some knowledge. Otherwise, he's fairly fine. The visual acuity at presentation was counting finger 1 meter. So he did have a profound visual loss, a severe visual loss, you can say. Right eye RAPD was there. Color vision, again, defective in the right eye, and left eye, we could read all the plates. So you have a young male who has a severe vision loss in the right eye, which he relates to trauma, and which progressed over maybe 2-3 days time. And this is what we saw in the fundus picture. Now you can see here maybe a grade 3 disc edema on the right side, and with extending into the, you can say, the peripapillary region, as well as a congested disc. On the left eye also there is some blurring here probably. So this disc edema probably with the profound loss of vision you would usually think in the atypical variety, and sudden visual loss, a pain, he says a dull pain. Previously he had severe pain, but then it's a dull pain. So all these features probably would not fit into a, you can say, a commoner variety of MS.
Jaspreet,
yes, ma'am.
If we go back to this picture, is it kind of acute, which you would like? It doesn't look very acute to me.
So acute in the sense it's a congested disc, and we don't have any, you can say, there is no sheathing of these vessels peripapillary. Probably when the disc edema is resolving, probably you have some of these issues. So you could have, he might have had a edema in the past, which has decreased, but yes, because he's giving a picture of you can say an acute visual loss, and with this congestion, probably I would call it maybe a few days only.
Yeah, go on, I agree.
So you have this patient, the significant features being counting fingers, disc edema, and a sudden onset. So these, what would one think probably? Should we investigate for MS, or should we think of atypical variety, even though the acute management is the same? So this is not a, you can say, a common presentation of MS. So the clinical diagnosis, of course, was optic neuritis. The visual field testing, the left eye did have some scotomas here, and the right eye, because of probably poor vision, could not be done. But yes, he has a visual field loss here in the right eye. So I mean, these are some clues that maybe the left eye had been affected earlier and probably went unnoticed. So he could have had recurrent attacks in the left eye, and the right eye probably now, because of a profound attack which is relating to a trauma, probably is what he presented with. So when you do these RNFL and the optic nerve head analysis of the nerve fiber layer, which is readily available, so that's why I said the first thing probably when the patient presents, you would get these things done. Of course, it's showing swelling in the right eye, and you can see some loss in the temporal quadrant here. So when we go ahead and do the ganglion cell analysis, what we find is you can see a ganglion cell loss in the left eye. So although the left eye had 6/6 vision, it has a ganglion cell loss, wherein the right eye probably he still has optic disc edema, and maybe an earlier presentation might not give you might not show you the actual damage, but the left eye is damaged. So probably it's maybe a sign that he has had some previous subclinical attacks of optic neuritis in the left eye, which have gone unnoticed, and now he presents in the other eye. So we get investigations done because again, it's an overlap between, it's more of like an atypical variety. I mean, considering all these signs and symptoms and the OCT analysis, but all these tests come out negative. So his MOG, NMO antibodies are also negative. The chest X-ray is within normal limit. And if we see, so we order an MRI. Obviously, MRI has to be ordered. We can't just depend on what the OCT is saying. So when we do an MRI, probably we see all these plaques. So these are like, you can say the active plaques probably. So there is no black holes. So if you see the black holes, probably as was discussed in the presentation of typical optic neuritis, probably that is what you call dissemination in time. So this is dissemination in space where you see multiple lesions, but dissemination in time means that yes, you have black holes along with the white marks. So this probably is just maybe this is the first time he's had these lesions in the brain. So if you get those the coronal sections done, basically the axial sections, the orbit would show the axial section would be showing the orbit. And once we see here, what these are showing is you can say like a Dawson fingers. So these are like these are around the periventricular region and extending to the corpus callosum. Now these Dawson fingers are very typical of multiple sclerosis. So he has some plaque in the cerebellum as well. So it's something which is there here and in the cerebellum as well. Now these lesions could be, this lesion could be there in NMO spectrum as well. So here what we have is an interspace irregularity, which is hyperintense on T2. It's along the corpus callosum. So basically these findings are more suggestive of a MS-related disease. Sorry. And if you see the axial scans here, what we are seeing is the T1 image, and here you have the T2 image. You can see here the involvement of the optic nerve. The optic nerve with some perineural enhancement. You can see here there is more of perineural enhancement than just the optic nerve, but there is thickening, and you can see it's just almost going posteriorly. Some thickening here as well, which is posterior. So I mean, these findings, just the brain findings are typical for MS, but all other findings probably are not really corroborating too well with the diagnosis of the MS. And yes, here again, you can see here that there's a perioptic CSF signal more here as compared to the other eye. So you have clinical symptoms which are atypical. You have an OCT finding, which is you can say is showing subclinical attacks in the left eye, and MRI brain, which is typical for MS, but MRI orbit is not really corroborating with this. You have disc edema. The MRI cervical spine. So whenever you get these the MR imaging, always get the spine done, and you can see here there is a hyperintensity involving the cervical spine, but it is limited to single vertebral segment. So if it's more than 3 or more than 3, probably that would be atypical, but here it's just limited to one segment. So all these things, even in oligoclonal bands, were absent when we got a CSF because of his, you can say, overlap in presentations, and we had to think for issues like cryptococcus as well. But yes, the acute management, we did give him methylpred for 3 days. Now, in the normal course, what happens is we were giving him methylpred for probably his vision deteriorated in the course of methylpred, in the sense it did not recover that much. So I think this is during this period, he really didn't improve that much. Probably the second day he comes and says, my vision is deteriorated. Then probably after 3 injections, his vision start to improve a bit. So the normal course of an optic neuritis, a typical optic neuritis, is of course deterioration and then improvement. And he did regain 6/12 vision probably on day 9. So that's the disc picture at presentation, and that's the disc probably on day 14. So you can see the disc edema has markedly resolved. In this patient, you do have some telltale signs, some blurring here. But yes, methylprednisolone did help, and his vision did recover. So the final diagnosis could be a remitting multiple sclerosis with right eye optic neuritis. Probably that was the only thing which was fitting according to the criteria. Maybe he hasn't come after that, and probably if he comes later, we'll have to see the clinical signs and symptoms before actually getting further investigations. So this 3-year, we have the third case is a 25-year male, again presents with diminution of vision in the left eye since 3 days. Sudden onset again, associated with pain, followed by similar episode of diminution of vision in the right eye since 2 days. So it's almost bilateral. So you can see here 612 vision in the right eye and a counting finger in the left eye. He has left eye RAPD and maybe an asymmetric involvement. So he has an RAPD in the left eye, but his color vision is fairly good in this eye. So the clinical diagnosis is a retrobulbar optic neuritis. We get his investigation, the basic blood investigation done. It's his ESR, CRP is normal, within normal range. AN is negative. All other things are fine. Then the important thing comes is the brain imaging. Now, when we get a CE MRI of the brain, there is no significant abnormality. The orbit optic nerve are within normal limit. Cervical dorsal spine, again, no significant abnormality. Basically, so there's no pathology in the spine as well. The visual field, yes, because the left eye had fairly poor vision. So we can see here there is some, you can see a central sparing here, but yes, all the peripheral involvement is there in the right eye, and the left eye probably was poor vision. So it obviously is just something which he just couldn't visualize on the visual field testing. Again, he was given IV methylpred, that's the acute management for 3 days. After 1 week, his vision is still counting fingers. His right eye vision is 612. So 5 doses, probably we gave 5 doses of IV methylpred. But after 1 month, probably he just starts to improve by himself, 618. We could have done a plasma exchange probably here and considered it. But he starts to improve after 1 month, and probably after 6 weeks, he regains 6.9. So sometimes, I mean, he did not, why we didn't do a plasma exchange, I remember, was that probably he was not willing for all these things. And so, I mean, destiny, he just, the vision improved to 6.9, and there was mild temporal dyspallor. The visual field is almost the same. Now he presents after 3 years with, and there is almost no vision in the left eye. So it's sudden loss of vision in the left eye since 2 days. Pain on eye movements in both the eyes. So mild temporal dyspallor, which is already there from the beginning. Diagnosed as recurrent isolated optic neuritis, get him investigated. Now this is an attack which has occurred after three years. So we need to get him, obviously treat him, but investigate him. And yes, what we find here is a MOG positive antibody. So something which started off, maybe the signs and symptoms were atypical. Probably a plasma exchange could have helped him, but yes, he did regain 6.9 vision, but now he becomes to be MOG positive. So his vision is 2/60 after 3 doses of IVMP. Now he's planned for Plex, probably. He's convinced that this is happening again and again. But the good point is, which is related to the MOG positivity probably, he regains 6.9 vision after a plasma exchange. So he's kept on oral prednisolone. But after 6 months, what happens? He now presents with sudden onset loss of vision in the right eye. So it's a recurring loss of vision, probably recurring episode. So it could be MOG, that's why I said could be a monophasic, or it could be recurrent. But yes, recurrent, what we're having is he regained vision first, he regained vision after a plasma exchange. Now he comes with a third episode. So again, start off with IV methylpred for 4 days. He basically regains vision. So that's the beauty of MOG probably. In most of these cases, even though there is profound vision loss, we have no perception of light in his left eye, but still he manages to have 6.9 vision. And yes, the visual field has also improved. After 3 months, vision is maintained. The disc is fairly healthy probably. We had probably a temporal pallor here probably. I think that was out of, probably the pictures are not, could be out of focus, but yes, fairly good optic disc, healthy optic disc he has. But the problem here is here. When you see the ganglion cell analysis, he has loss of ganglion cell in both the eyes. So that means it has been going on in both the eyes for quite some time, even though his nerve fiber layer is fairly healthy. So this is a sensitive indicator of what is going on in patients of optic neuritis. It can give you a clue whether this patient has had previous subclinical attacks and how you need to manage these patients. So, and the next case is like a 35-year-old female who comes with blurring of vision in both eyes since 10 days. And it's a dull intermittent headache of 2 to 3 days duration. The vision is gradual, painless, and progressive. Very dull headache, but no pain on eye movements. She has 660 in the right eye with the right RAPD, temporal parallel. Again, because of this atypical features, we get her tested for the NMO MOG and she's MOG positive. But the MRI brain and orbit is within normal limit. So the MOG is positive here. You give her IV methylprednisolone for 5 days, followed by oral steroids. She went to obviously we had to have a neurology referral for starting her on these immunomodulators, and she is sustaining vision after rituximab. So after 3 months, vision is well maintained, even though there is temporal pallor. And but yes, this you have to be careful. Basically, this is rituximab is given by the neurologist, and probably basically you can say in accordance with them when we do the management, she developed B-cell lymphopenia and had to be started on immunosuppressive drugs. But after 6 months, her vision is well maintained, even though she has a pale disc. So pale disc doesn't mean that you will have loss of vision. You just require 1/3 of the working nerve fibers to have 6/6 vision. The OCT, yes, that you have a RNFL loss here and a ganglion cell loss as well. So something which have to be careful when you have these things in like a pale disc, you have to have a close follow-up, because anytime it's like a cliff. Anytime you can just fall down. This ganglion cell can fall down and you will have like loss of vision. So you have to have you can say a close follow-up when you have patients with optic neuritis maintaining vision, pale disc, and a GCL showing such a picture. So probably the last case, what we have, so this is a young female who comes with 6/6 vision, but has blurring of vision, she says, since 15 days. But you test her vision is 6/6. The important clues here, she could only read the demo plate. So even though there is the pupillary reactions are fine, the vision is okay, but one of the earliest indications is color vision. So that is an early indication of optic neuropathy. So when you have this, you should be suspicious that you need to evaluate for optic nerve disorders. See here, of course, there was some pallor here when you do the examination, and some pallor on this side as well. Not that healthy looking, but yes, more on the right side. But again, she's maintaining 6/6. The visual field is fairly fine. And when you do the OCT analysis for the RNFL, probably what you see is there is a loss in the right eye, whereas some loss in the left eye, the yellowish region. So with a 6/6 vision, she's having RNFL loss. She has a dyspallor in this eye. And when you do the ganglion cell analysis, there it is. You have a loss in the right eye as well as the left eye. So her blurring of vision probably is just a subclinical attack. She could be having it for maybe may have had a number of attacks, or for this to happen for the ganglion cell, and even though she's having 6/6 vision. So with this, something in the OPD, something which gave us a clue that we need to investigate her and manage her on the lines of could be an optic neuropathy. Probably we did investigate her, and although her NMO and MOG antibodies were negative, the CE MRI showed the plaques for multiple sclerosis. So how some blurring of vision and doing an OCT and with a little more clinical findings helps us to maybe investigate the patient on the proper lines and then start her on treatment. So this is basically, these are the few cases, a different variety of cases of typical, atypical optic neuritis, and how OCT is useful in all these things. And those cases which could be like infectious optic neuropathy, and the clues which one should look for when you're dealing with patients of optic neuritis. Yes, I'd like to invite comments from Dr. Vishali and Dr. Diksha. Any final comments before we close down? Any?
There is a question. Have you answered the other ones? How do you do plasma exchange?
Yeah, so plasma exchange is obviously not our domain, probably. It's done in the neurology department, probably. It's obviously taking the blood, obviously going through the machine and taking out the antibodies and all. So that's done by the neurologist, not our domain as well. That's a form of, you can say, a very effective form of management for the antibody-related optic neuritis.
I have a question, like in a number of cases that you have shown, there was evidence of ganglion cell loss, even if the patient's eyes was, even if the patient was asymptomatic, and one of the last ones had typical MS plaques on the MRI. So does OCT, this GCL, and contribute to those categories of dissemination in space or dissemination in time? I mean, the GCL evidence of thinning and the presence of this without any clinical evidence of optic neuritis at this time, and evidence of plaques like MS plaques, would that does that fit into dissemination and is time, is it included in those dissemination in time definition?
Not really. I think OCT is just you can just say a guiding tool. You can't be basically limiting you're making a diagnosis based on the OCT, on the GCL findings, because these are seen in numerous other conditions as well. So you have to, they're just you can say a helpful tool where you can tailor your investigations accordingly. I mean, if you think the GCL is normal and the patient like has come with a typical optic neuritis, probably you can follow up without ordering all the other investigations like a MOG or an NMO, unless the patient has a recurrence of that sort. But yes, if you have a GCL, which is, you have severe loss of GCL and a patient presents with these things, probably you would try to get other investigations, probably look for the antibodies as well, because it's been shown that that the loss of ganglion cell is much more in cases of atypical optic neuritis. But yes, there is so much overlap. It's difficult to just base your diagnosis on and manage a patient on OCT. It's just maybe a follow-up tool, you can say.
Yes. So another question. Yes, ma'am. So just another question, like for example, the baseline MRI in a patient who's suspected of typical optic neuritis come out to be normal. So when should the MRI next be repeated? How often?
Yeah, so this is again, you can say a question which is the answer which is related to the symptoms. What is said is probably in a typical optic neuritis, if you're suspecting typical optic neuritis, probably you would order an MRI probably yearly for the first 5 years, because that is the time when they convert to MS. So there's a high incidence of conversion to MS in these cases. In those who are those who have no findings on MRI, although the incidence is less, but the first 5 years is the most crucial. But for atypical optic neuritis, yes, you have cervical spine screening, which has to be done, transverse myelitis, which is common. Many times MRI would be normal. The orbital picture might give you a clue to all these things. So at that time, probably if you're going with the atypical variety, probably yes, you can start managing. But everything else is normal, probably yes, maybe an annual MRI.
Just present instruction courses for comprehensive ophthalmologists. How would you advise them to go about in case they do not have a very easy access to NMOs and aquaporins and even a neurologist? So till the time the patient is able to see these people, how should they follow up the patient?
Yes, so it's that's a very important thing and a very, very good question. As I told, I mean, the diagnosis of optic neuritis is clinical. So clinically means if the patient, you have a young lady coming up with loss of vision in one eye, maybe progressive, having an RAPT and a color vision deficit. So the diagnosis, and if you see nothing on the fundus, probably you're dealing with a retrobulbar optic neuritis. The important thing is, even if you can't differentiate whether it's typical or atypical, the one thing you can start off is give them IV methylprednisolone, because what happens is you are going to decrease the disability what the patient is going to have. The destruction would is at the onset of the attack. The findings come up later. So you have inflammation when the patient presents to you. You have to decrease the inflammation so that the sequelae are limited. And thereafter, if you don't have access to all these things, probably you can refer the patient.
But the role of concentration, visual field, or color vision, which we did not really.
Yeah, so ma'am, so the color vision is one of the important clues. But these patients really they say it would come with decreased vision, some decreased vision. So it could be like a moderate loss of vision or maybe a severe loss of vision. So in those cases, probably if you can do a color vision, probably it's one of the sensitive indicators you're dealing with the case of optic neuritis. But even some kinds of macular problems can also have color vision deficits, because it all starts in the ganglion cell layer and then goes on to the optic nerve. But yes, the visual field testing, if you do a confrontation test, and if you can find that it's a central scotoma along with other findings, along with the other symptoms and signs, yes, you can probably narrow down your diagnosis and start the patient with the IV steroids. So you can say the history is important. In the clinic, yes, we still have 2-3 minutes. So in the clinic, what you can do is like Dr. Vishali has just said, a confrontation is very easy. So you can just ask the patient you can just count fingers left or right. I mean, what you can do color vision testing with the Shiara book, very easy. We test the RAPD. So that's again an important pointer. So these are some of the things which a general ophthalmologist can do, and and give the patient a trial of steroids before referring them. But yes, there's a lot of overlap in conditions. We don't know who will relapse and who will not. So probably there's still a gray area. So of course, if you have you can say test like antibodies for NMO, test for MMOG, probably we can get those things done in patients, because if you have them, why not get it done? And probably
just breathe.
Yes.
Just breathe for this wonderful session.
So probably yes, probably we can just wind up. And any last comments? Any last comments from our panelists? Infectious optic neuropathy. We should look.
Just be careful. Just look for it.
Thank you so much, sir. It was an amazing session here, and also thank you for making this session wonderful.
Thank you.
Thank you so much. Stay safe, and thank you for being with us.
Thank you.
Thank you.